welcome all of the distance learning sites back from the short stretch break, and those of you who are in our audience here who I didn't see this morning when we first started, it's nice to see you now, and welcome. And I'm actually going to be talking about oral assessment, and one of the things that we're going to have in the next hour, hopefully, with Dr. Elizabeth Lane, is going to be the overall assessment of an older individual. And if we don't see her, it's because she will have run off to go have her baby. So it's imminent. And if that's the case, that she doesn't quite make it, we do have her handout. We can talk a little bit about it. But I thought that one of the most important things that awfully frequently gets neglected is the issue of oral assessment. And so many of our older patients have oral problems that really affect them systemically. And in addition to oral cancer, which, as you know, is one of the primary worries that we have in older patients, for example, there are 13,000 new cases of oral cancer every year, and 6% of all cancers in men are oral, and most of these individuals are over 65, and 4% in women, and that's increasing. So it becomes a very important issue for us as we screen older patients for oral cancer, but also when things don't get treated and someone has an oral infection that proceeds to become systemic, you can see on the slide at this point that some of the possible sequelae that result from oral infection that goes untreated can be as severe as cerebral abscess, and a lot of people know about bacterial endocarditis as an important concern, osteomyelitis, and of course septicemia. And we see that more and more in nursing home patients or other patients who are incredibly frail, who are already multiply challenged by comorbid illness, and having an oral infection is just one more thing that the body has to put up with and often has a very difficult time doing. So what I thought I'd do is actually go through some of the process and occasionally refer to the handout so that you'll have the opportunity to look at the handout later on your own time. I don't want to be one of those folks who stands up and just reviews the handout. Rather, that's sort of supplementary information. I'd rather show you some gory slides so you'll really get a fuller appreciation of what it is we have to deal with in some of our older patients. And you like gore, and you've had lunch, it's been a while, and so, and hopefully the folks at our Kerrville and Corpus Christi and any of the other El Paso or UTEP sites who are there will be equally at ease. And the first slide actually is of the finger of a nurse. And this was a nurse who decided to do an oral screening and didn't wear gloves. So the number one rule of doing oral screening is wear gloves. And the reason for that is this is herpetic Whitlow, and there are a lot of individuals who have herpetic lesions that erupt on the lips, not even just intraorally, but on the lips, and they are prodromal in nature, which means that there's sometimes a tingling, sometimes there are actually virus that are on, I don't know, is the plural virus, viruses? In any case, there are multiple lesions that are waiting to happen and don't happen immediately, and there can be a prodromal time where there are actually virus on the surface of the skin just waiting to hop onto whoever touches it. So that's important to always wear gloves. And this is a shot here of actually a young individual with a very severe herpetic lesion. And I think the important thing about this is that in older patients who have other comorbid illness, a simple herpetic infection will often appear much worse than it would have if they were 20 or 30 years younger, because again, their body has a harder time often fighting the infection. Their immune system is already challenged with other problems that they have going on. Now, in your handout, and the folks again at the distance learning sites We had the handout ready to overnight to you last night, but it occurred to us, one of the things that occurred to us was that you would have a hectic enough day and morning getting set up that you didn't need to be duplicating handouts as well. But this is on the back of the first page, and it actually, well, it's page 2, I guess. It's not on the back. It is a drawing that was done by the National Institute of Dental and Craniofacial Research for their training manual on doing oral screenings and oral cancer exams, as well as looking at hard tissue, such as teeth and bone. And it progresses from A to Z, and it's accompanied on the sheet of paper by the directions on how to proceed. So it's very straightforward. And the first thing that we tell people to do when they're going to do a screening of any kind that's oral is actually to look at the face. And could I have a glass of that tea that I was drinking? I have to excuse myself. I have a terrible allergy. It's cedar season up here in San Antonio. While I could roll in cedar and not be affected, it also happens to be mold season. So I'm suffering with mold. This is Mr. Shepard. And he's in his 60s. And I'd sort of like participation on this one. What's the first thing you notice when you look at his face? Not symmetrical. What about his eyes?
His right eye is squinty.
His right eye is squinty. Mm-hmm. What about his denture, his upper denture? What do you notice?
It tends to droop on the left side.
It's drooping on the left side. Okay. That's very, very good. And the reason for this is that Mr. Shepard had an oral cancer surgery. And if the slide went a little lower, you would see the scarring where he had his tracheotomy. And he had what he thought was a denture ulcer on his palate. And he ignored it. And he ignored it for about 6 months until it took over his entire palate, sort of ate it up. And he knew he had cancer at that point. I mean, there was no question this was no longer a denture ulcer. And he finally came in to see what could happen. And what did happen was they removed, obviously, almost all of his palate and bone, almost all the way up to the orbit of his eye. And he has a prosthesis that he is wearing that has a huge foot on it that fits up into the defect. And it's hollow, so it's not as heavy, but because he doesn't have anything on that left side holding it up, that's why it's drooping. So that was a very good observation. Now, I thought the most important things to show you is what normal looks like. Because in order to know what's abnormal, you have to know what normal and healthy looks like. This is a colleague of mine who has obviously gorgeous teeth. And this is what a mouth is supposed to look like. And you can see that the tissue surrounding the teeth is somewhat lighter colored than the tissue that's a little bit farther away, that's redder. That's where the attached gingiva begins to separate, and you have the alveolar mucosa that's movable. And that's why the change in color. So you get a good idea of what it's supposed to look like. Now I'll show you what a normal maxilla without teeth is supposed to look like. This is relatively normal. And this is someone with a pretty good ridge. And you see all the bumps anteriorly, and which would be the top of the slide towards the front of the mouth. Those are rugae, and those are like fingerprints. Everyone has their own unique pattern. However, since most folks who don't have teeth will lose bone, then the shape of the rugae will change. And if they get infections from Candida albicans or some other problem, then they get further distorted. The same thing for lips. You have a unique set of lip prints as well. So you can see where it's obvious that fingerprints are going to be the least likely things to change. Those are the things people use most for IDs. And in dentistry, of course, we use x-rays because x-rays are very unique. Okay. This is an edentulous individual. We've looked at a face. Now we're going to start zoning in more on what the oral and perioral area looks like. And what do you notice about this individual's mouth? irritation at the corners. This is called angular cheilitis, and it can be caused by a number of things. One of them is being overclosed. In other words, here is someone who looks like he's not wearing dentures. Maybe he doesn't have dentures. Or maybe he has dentures that are 30 years old and are so worn down that something called his vertical dimension of occlusion is no longer present. And that's the distance that you're supposed to have to separate your teeth one from the other when you chew or bite, and certainly your nose from your chin. And a lot of you have seen those old cartoons where noses and chins begin to approximate one another because not only are the teeth gone, but the bone has resorbed as well. Well, if you think about it, the thing that keeps your face shape and your bone where it is around your mouth, it's your teeth. So there's no reason to have that anymore once you lose teeth. It's another good reason to keep those teeth. In that case, when someone is overclosed, then saliva will pool in the corners of the mouth, set up an irritation, and Candida albicans often moves in as it would here. Other reasons would be in diabetics who are more inclined to have Candida albicans infections, and other individuals who may be immune compromised can get this as well. Okay, now we're looking not only at the exterior of the mouth, but a little of the interior as well. And what do you see in this one?
It almost seems like he's got petechiae on the lower lip.
Mm-hmm. And I think what you're looking at, in addition to petechiae on the lower lip, is a very, very dry mouth. Very dry. And that tongue looks almost painful, it's so dry. And while we do see dry mouth a lot in older individuals, the vast majority of them who have dry mouth, it's because of the medications they're taking. Almost every medication you take as an older adult, whether it's for cardiovascular conditions or cerebrovascular conditions or almost any other problem, has some sort of negative anticholinergic effect on the mouth, and it dries. And this is an example of someone who has had head and neck cancer and who has had radiation. So they get extremely dry. And over time, this does not always come back. In a lot of chemotherapy and radiation patients who have dry mouth, depending on the radiation dose, they will often experience some resurgence of saliva over time, but not to the extent it once was, and in a great many cases it never comes back.
Well, in just the elderly, is that just a sign of aging too, that you have a decrease in the saliva production?
Actually, that's a very good question, because in the 50s through 70s, the beginning research that was done in that area, the results showed that yes, indeed, it looked like as you aged, you lost the ability to salivate as much. Then it was discovered that they didn't correct on any of the data for the individuals who were taking anticholinergic medications. So then they decided for another 10 years that there was no change and that it was really just an artifact of the medication people were taking, or a side effect. Well, we've had a research center on oral health and aging here that I direct, and we have had a 6-year study going on of aging. And one of the things that we've discovered is, you know what? They were right back in the 50s to the 70s, only they didn't know it because they didn't correct in their data, but it's actually true. There is some decrease in salivary flow. So but one thing we don't know is how dry is dry. How dry is dry enough to cause something like rampant caries? Because your saliva is a very protective fluid. It washes the bacteria off your teeth. It has secretory IgA, immunoglobulin A, which is part of your immune system to help fight against these things. And how much of it do you have to have or not have before disease sets in?
How much does the loss of the thirst reflex in the elderly contribute to that too? Is that a part of it also?
Exactly, that's part of the picture as well. And now here we have a slide of an older gentleman's mouth, and what do you notice about his lips?
Ulcers.
Ulcers, yes, he certainly has a depressed area, and as you're facing the screen, if you look on the lower lip, his lower right, your lower left, you can see an area. I don't know if I put my finger on it, will it show up? Not there, but it will up here. Okay, in that area. And one of the things that a lot of older individuals, particularly older men who do a lot of outside work, have as a problem as they age, we all have thinning skin, but if they're doing outside work and they're too unwilling to protect their lips with sunblock, we see a lot of actinic keratitis, where there's actually damage to the surface of the skin. And over time, some of this can actually become squamous cell carcinoma or basal of the lip, or basal cell carcinoma on the face itself. And with that in mind, the next slide I'm going to show you after this one is an individual who had in his 60s a basal cell carcinoma lesion on his temple, and had lost both his mother and his wife 20 years earlier to cancer, and only knew from 20 years earlier what the treatment for cancer was told he had a basal cell cancer that they could remove, and before they had a chance to really let him know how secure that was, how non-progressive, how curable, he disappeared into his trailer for 10 years. And when I saw him after that 10-year period, it was because a community health nurse had finally come to see him from the Veterans Administration, and this is how he came in. This is actually after I treated him. The consult I got from the oncologist was loose dentures, and I went up and I saw the big barrier sign on the door with isolation all over. He had come in with a Pseudomonas infection and lice, and what you see here basically is the antibiotic ointment placed on there to get rid of the Pseudomonas. And the other side of his face, which you can't see, there's a little more face, but both of his eyes are gone, and his nose, and you could, get close enough, you could see his nasal concha and everything. And there was only one nurse who could understand him. And this nurse was so fabulous that when he slept, she went home and slept, and when he was awake, she was there, and she never left. He lived for 3 weeks, and I talked with his daughter, who had a tremendous amount of guilt because there was nothing she could do to get him to come in to see anyone until he was so weak and cachectic that we literally had all the reason then to bring him in. And his daughter said his favorite food in the whole world were those liquid cherry candies. So I said, by God, this man's going to have his last days eating those liquid cherry candies. And we got him an orthodontic cap headset and a bunch of blue and pink acrylic that we use to make denture bases for trays for try-ins, and put a real soft lining material in it. And I mean, we've got wing nuts and bolts on there, and he was able for about 2 of those 3 remaining weeks to have those liquid cherry candies, in addition to the liquid syringe of food that they fed him several times a day. And when he wore this, even I, believe it or not, could understand him a little, very little. Think about how much your palate and your upper face and the resonance in your head play in how you sound and your understandability to others. Here is another area there where you would want to look, certainly, and that's called the vestibule, the labial vestibule, where you pull the lip and cheek to the side and have a nice look. And this is leukoplakia. It's a white lesion, and the first thought is, well, my goodness, is this cancerous? Until you start asking questions and you find out that a day earlier the patient had a toothache, had called the dentist. The dentist had said, take 2 aspirin. We're totally mobbed with patients. We can't see you for a couple of days yet. I'll call in a pain prescription if it's terrible, blah, blah, blah. And basically what you've got here is an aspirin burn, because he didn't take the aspirin with water, he just put it next to the tooth. So sometimes you have to be extremely clear. This one, however, this anterior lesion in an edentulous person on the lower floor of the mouth, the most common places for oral cancer are on the floor of the mouth and the posterolateral border of the tongue. And what we're trying to do is get our non-dentist colleagues to do more than just look at the pharynx. You've got to look anterior to the pharynx to see what's going on in an individual. The mouth is part of the body. So it becomes very important to have people stick their tongue out and grab it with a gauze and pull it to the side and have a pen light, a light source of some kind, to look at the posterolateral border of the tongue where you can't see what's there. And again, to look at a whole bunch of normal tongues so you know what they look like before you start trying to figure out what's abnormal. This is a squamous cell carcinoma lesion of the floor of the mouth, and it's white with some pink and red involvement as well.
How much deformity occurs when those kinds of squamous cell carcinomas are removed these days? I mean, has it decreased dramatically from what it used to be?
No.
No?
It's every bit as extensive as surgery, because oral cancer is one of the deadliest. People who have them, they often go undetected for long periods of time, and often till it's too late, which is why we're trying to get other healthcare practitioners to do oral screening as well. The sooner you get any cancer, obviously, the likelier someone will do to do better. And oral cancers tend to spread rather rapidly and metastasize quickly. This is the floor of the mouth, and you see a number of ulcers there. And these are actually aphthous stomatitis. These are recurrent lesions. They have usually some sort of emotional component attached to them. If someone is under stress and they're prone to get aphthous ulcers, they'll get a lot more often. And they will linger for 10 to 14 days and be extremely uncomfortable. And this is an individual who has a slew of them going on. And obviously it's an older individual, and you can see on the backs of those lower teeth, a lot of calculus and plaque built up there. And individuals who are very ill are stressed by their illness. So it's not uncommon to see one disorder bring something else into play. What you're looking at here is herpes zoster, and you know that shingles is essentially recurrent chickenpox, and that it is extremely sensitive, and most individuals get it on the trunk of the body, but it is not uncommon to have it on the head, face, neck, or intraorally in this case, and it's usually on one side or the other, and is unbelievably painful.
At the same time you have the skin lesions, or is
Not always. Not always. This gentleman most likely, because it is the maxillary nerve that's involved, most likely has some lesions on his lip, possibly on his face. I had one patient who had his forehead, his whole right side of his face, from his balding head across his eyelid. He had a risk for going blind, all down, stopped at the upper lip and went in the mouth. And he was in agony and had quite a lot of scarring, and he was very lucky he didn't lose his vision. But it's not uncommon to actually lose patients, elder patients in nursing homes who get shingles, and their bodies just have a terrible time fighting it. It becomes a systemic problem. And also we look for all sorts of blebs, bubbles, bumps, lumps, and what have you. This is an edentulous upper right side of a patient. This is what you see, the piece of tissue sticking out on the left that almost looks like an arch, is called a frenum, and it's an attachment of the lip to the movable tissue. And he could have anything there from a hemangioma to an infected root tip that's left behind after his extractions, that's now breaking through to the surface, to a wart of some sort of verrucous lesion. Another skin condition that we often see in the mouth that is again more often seen on the body is something called lichen planus. And you can see there this is the most classic slide of intraoral lichen planus I have ever seen, where you have white striae that look very web-like and this sort of yellow butterfly almost shaped lesion surrounded by a red halo. That is classic, and more often than not you'll see white striae or red, and you won't often see the butterfly lesion. And this is another one of those intraoral things that's incredibly painful. And well, the same way you would treat it were it on the surface of the skin, it is treated by systemic steroid. Remember when I said it was very important to look at the posterolateral surface of the tongue? This is the posterolateral surface of a gentleman's tongue, and it's not all that far back. And it's obviously some sort of ulcer. And when this was one that was seen in our graduate clinic by some of our postdoctoral students, and it was right next to some lower posterior teeth. I think they were like second molars, where on the other side of the tongue there was no roughness, and on this side of the tongue that second molar was jagged, it was fractured, and it looked like it was probably a traumatic lesion. So what they did was gave the gentleman some particular ointment to put on there, go home, come back in 7 to 10 days, and they'd see if it had resolved or improved, and it had not. So that worried them, and then they decided to biopsy the lesion. So they biopsied the lesion, and from here it went from bad to worse, where there was this gigantic defect in the tongue that wouldn't close and it looked infected, and it ended up having to be partially resected in order to close it. And that was because this gentleman had diabetes and didn't know it. And certainly in Texas and a lot of other places, we have a tremendous number of diabetics, probably half of whom don't even know they have the disease. So we have to always be alert when confronted with individuals and suspicious lesions to make sure that we're screening for diabetes as well. And in fact, in the dental office, I'm advising a lot of individuals to screen for diabetes in all Mexican Americans over 40, all blacks over 55, and everyone who's obese over 60. This gentleman, this is called brown hairy tongue, by the way. It's not hair. This is an overgrowth of your filiform papillae, which are normal parts of the tongue that are associated with the tongue being able to function and cleanse itself and help taste, along with the taste buds, that they help capture the food particles long enough so you can taste them. Well, this gentleman had an overgrowth and was a smoker. And his breath was so horrendous that even though he liked to play the piano, no one ever came over and listened to him play the piano in the retirement center. And he was kind of depressed about that. And when he came in for his routine checkup, we figured out why. Excuse me. Because his breath was so horrendous. The solution to this is to actually brush the tongue, but not with a toothbrush. We actually mix something one of my colleagues invented called Langley's Miracle Paste, where you take toothpaste, mouthwash, and some pumice, this gritty stuff you remember when you go and get your teeth cleaned, together until it's a creamy, pasty consistency, and scrub the tongue with a denture brush, a real hard brush, and the stuff comes off like rug fuzz. And this is what his tongue looked like after we denuded it. And you can see he has a lot of red areas. He has geographic tongue. That's a variation of normal. And it's obviously tender since it's been so abused. And it took a couple days for all that stuff to finally come off. But what you see almost in the center is a white spot. And this man was a smoker. So this is a very suspicious lesion, and we did biopsy it, and he was very lucky. It was hyperkeratotic in nature. It was just thickened tongue in that area, the epidermal covering. And he was lucky that he didn't have cancer already. So in another patient, maybe it would already have been, and no one would have known for a long, long time. The reason I've been talking so much about nursing home patients is because we have so many individuals who are either homebound or in nursing homes, and that this number is consistently increasing to the point where we're already at 2.2 million individuals in nursing homes. So that's quite a lot of folks, and that number, of course, is expected to go all the way up to 5.4 million by 2050. I hope that's not true. I hope that we truly do right by our seniors and others and have better home health services so people can stay where it is they're most comfortable for as long as possible, and that would be in their home. This is a gentleman with Alzheimer's disease, early Alzheimer's disease, and one of the things that happens with a lot of individuals with Alzheimer's disease, even in the early stages, is they forget about brushing their teeth or about parts of brushing their teeth. They'll maybe remember what the toothbrush and the toothpaste are, and then don't remember what to do with them. And early enough in the disease, they can certainly continue to read and understand short reminders, so those are good things to do for them. And in his case, this is what he looked like after we cleaned his teeth. And this is what he looked like before. So you looked at that, and he was a smoker, obviously. You didn't know what you were looking at. Are we looking at cavities here? What is this? And in this case, it was just filth. This is an individual who was not only a smoker, but a cancer survivor, and he has rampant caries and is beginning to have amputation caries where the teeth break off at the gum line. And that's a really serious condition. We don't want to have to extract teeth in anyone who's had radiation because of the danger of osteoradionecrosis. So we want to get everything out before radiation, and all we need is 2 weeks. That's one of the things we try to encourage our physician colleagues to do, is once you've found the cancer, send them to us immediately so we can save what we can, remove what we can't, and start giving them training right away on how to save what's left. And here's a close-up of another individual who's lost a number of teeth from rampant caries of one of the teeth that is fractured off. What we see quite often is a lot of neglect from individuals themselves who can no longer brush, or in extended care facilities where staff are too understaffed, or too few of them, or too little inclined to help clean the mouths of the individuals there. And these are the kinds of results we see, where you have lots of plaque, lots of calculus, swollen gums, and bone and tissue that recedes away until teeth are so loose and have to be removed, or there becomes a systemic problem like a septicemia. We've lost a number of nursing home residents throughout the country to septicemias where the pathologist, on doing the autopsy, found that the only nidus of the infection was oral. So that no one should have to die in a nursing home from an infected tooth if they're not dying from infected toes. And well, this isn't as bad as I thought it was. I thought this slide was pretty dark, but here is an older man with a lot of dryness in his mouth, and again, also swollen tissue, a lot of calculus and plaque. These are real folks. This is an individual who had had a stroke, and Mr. Rademacher, and we had talked with him a lot about his home care, and he was doing a very good job on his left side, which is your right side. But if you look on his lower right, your lower left, you can see those posterior teeth. You can see the pink, you can see some plaque there. One of the things that happens is affected side neglect. So individuals who are still doing their own oral self-care, who have had a stroke, really need some help with that affected side in the way of reminders and assistance sometimes. And here's one who had absolutely no care. And I think the important part about this individual was that right up there on the medication form in the nursing home chart, it said those teeth were brushed every day, along with the medication being given. Now, I'll eat my hat if I had one on, if that was going on. So there's a lot of guilt on the part of staff who don't have the time to do the kind of assistance with oral hygiene that they ought to be doing. And the nursing home law, which now is finally requiring that nursing facilities be directly responsible for the dental care of their residents, now that they're actually finally, after 11 years of that being in effect, going to begin to enforce it, there is a penalty of $10,000 a day for violations. So we're hoping that sooner or later someone will actually get penalized, and maybe then it will become important enough that we'll see folks not having to be confronted with the septicemias that result because of the neglect. And in addition to teeth, we have to remember there are dentures we need to look at as well. And people wear the most unbelievably awful dentures. This is a brand new set, so they're in pretty good shape. But this is one where there's been a fracture and an attempted repair. And when you wear something like that, you get an overgrowth of tissue called epulus fissuratum, and it becomes a trap for obviously bacteria, food, and everything else. Ulcerates rather easily and can cause serious problems. So we like to remove those when we see them. Certainly people need new dentures. And remember I showed you what a normal healthy palate looks like in an edentulous person? See how different this one is? This is someone who has some hypertrophy, clearly some hyperplasia, some candidiasis all going on at the same time. And you can see that the rugae are almost non-existent because the swelling is so extensive. And here's one that's the opposite. They've lost, this gentleman has lost a tremendous amount of ridge. He's lost a lot of bone, has nothing to support a denture, that's all flabby tissue. And in fact, he's a bit anemic, and we picked up his anemia before the blood test results came back just by looking at his palate. You can see a lot of systemic conditions just by looking in the mouth.
Well, those people that have lost all of the bone, that have had dentures but have not worn them for years and years, there's really not anything that you can do then, is there?
There are implants that they do now if someone is well enough to withstand something like that.
We're talking 90-year-old people, you're not going to be...
Not unless they intend to live another 10 years and they want an implant, which would be very unusual. I haven't seen too many really super healthy 90-year-olds, but I predict that in the future we'll be seeing some. I don't know if you've seen the shot of the 80-some-year-old psychiatrist who's the bodybuilder. I'm sure if that man were edentulous and had a ridge problem when he's 90, he's going to want an implant.
Those people
you know.
who like that are demented and do not have dentures, what do you recommend is the best way to provide oral care for them?
Swabbing. They need to be swabbed, and you swab with something moist, obviously, because their tissues are thinner and more friable.
Lemon glycerin swabs?
Never use a lemon glycerin swab because they're drying. So you're better off just using salt water or water.
Would work?
Sure. Whatever is going to be soft and gentle. And the next few slides I'm just about through are just to remind you that in nursing homes now we have minimum data sets that are required. We were able back in the late 80s to get oral health included, and that when individuals look at the oral problems and fill out the triggers form on the oral problems, you'll discover that of the 18 resident assessment protocols, there are a number of them, and you can see here, that will confound oral findings and be either directly responsible for, indirectly responsible for, or affected by the oral problems. And when you look at Section E, which is the physical functioning and structural problems, this is everything on here, you know, with the basic activities of daily living and so forth. They stick the oral issues there are underneath grooming. It's sort of like if you can comb your hair, you most likely can brush your teeth, and if you can't, you probably won't be able to brush your teeth either. And then Section L is oral and nutritional status, and Section M is the oral dental status. And what we've been trying to do is get nursing staff, particularly the directors of nursing, who quite often are the individuals who have to fill out the minimum data sets in that first 14 days of admission, and are responsible for doing, and should be responsible for doing, the dental screenings, that we give them some assistance in helping them do that. And to that end, I put together for the American Society for Geriatric Dentistry 2 manuals, one for the dental office and one for the nursing facility, on how to set up a dental program. And there's both a slide set and a videotape for the RN on how to do this screening exam and look for these things. And I think obviously the bottom line is we want happy older individuals, whether they're institutionalized or not, and to recognize that whatever happens in their mouths impacts them in a much greater way. This lady, Nell Simpson, was 81 years old, had had a stroke. You can tell by looking at her that when she was a young woman, she was absolutely gorgeous, because she's absolutely gorgeous at 81. And she had had a mild stroke and was not participating in any therapy, was being antisocial, and wasn't smiling, was just being a loner, and they were getting ready to write her off, and it was time for her annual dental screening. And when I saw her, this is the after picture. When I saw her, she had dentures that looked like horse teeth. They were hideous, they were horrible. And of course she wasn't going to smile. At 81, even with a stroke, this was a woman who cared about how she looked. We made her a new set of dentures. She participated in her therapy. She eventually went home. There's a role, I think, for oral health and general health and vice versa, and I'd just like to see more of us cooperate to help make all that happen. And thank you very much, and we can go ahead and turn that off.
Where do we get your videotape and your slide program?
Well, you can get the phone number from Lily later.
Yes, the nursing.
Yeah.
Oh, you bet. Look at that.
Okay.
I have a question, please.
Yes, indeed.
Yes, you mentioned something about you don't remove any teeth before they have, or during radiation. Why is that?
What we want to do is remove teeth at least 2 weeks before radiation therapy because of the risk for osteoradionecrosis. If you have to remove a tooth, it's very likely to develop an infection once there's been radiation because of the loss of blood flow to the area. So it's just set up there to have a total resection of a part of the face if the infection and radionecrosis occurs. So that's why we have to do, extractions early.
So that's a lot like ABN then, avexlar necrosis in a broken
That's
bone.
exactly what it is. Any other questions?
That was very interesting.
Okay.
She asked, is that only radiation for your mouth, or would that be radiation anywhere on your body, say a lung cancer?
No, it's for head and neck radiation. That's another thing we need to see more of, is shielding of the intraoral area during neck radiation. We've got a long way to go before that happens. But we're trying. I'll get my CD-ROM out of here and disappear from view. And you'll all be happy to hear that Dr. Elaine, I'm sure she's not happy about it, but we're all happy to hear she's not had her baby yet, and she is here.
Bus comes down, spinning wheel, got to go round, talking about your troubles. It's